OsteoSignal, Episode 15. This is OsteoSignal with Neal D. O'Neill, a podcast exploring how your body's natural design connects with osteopathic science. Translating complex signals into practical insights so you can truly thrive.
Welcome back to the OsteoSignal podcast. I'm Neal O'Neill, and this podcast is dedicated to helping you understand the osteopathic model of health so that you can move better, adapt better, and truly thrive in life. And today I'm joined by...
I'm Autumn Mayberry, and I'm one of Neal's students.
Hi there, I'm Brent Mayberry. I'm Autumn's husband, and I'm here just to be a fly on the wall, ask questions, and facilitate discussion. Good to be with you.
Yeah, thank you both for being here. That's awesome. Okay, and thank you both for the help. Okay, so in our last episode, we discussed new research showing how movement activates biological pathways that keep bones strong. Today, we're going to dig a little deeper. We're going to look at what actually allows movement to feel safe and coordinated, and how restoring joint motion after injury can literally restore the nervous system's ability to guide movement. Let me tell you about a patient recovering from a hip fracture. So I have a patient in their late 60s, suffered a fall at home and fractured their hip. They underwent surgery with placement of a medullary nail fixation. The bone healed successfully.
Neal, could you maybe explain a little bit about what's involved with that?
So I have a patient in their late 60s, suffered a fall at home and fractured their hip. After x-rays and looking at it, the doctor decided that instead of a hip replacement, even though they were late 60s, that they wanted to go ahead and reattach the two bones together. And so they use what's called a medullary nail fixation. Medullary just means it goes through the middle of the bone. And so then they basically take the two pieces of bone and they put a big screw through them. They call it a nail, but it's a screw. And they attach those two pieces of bone together because they're both healthy pieces of bone. So they were a good candidate. That means they're very healthy. They can set down bone. So it was a pretty optimistic situation for the patient. And
awesome, right? Thanks for explaining.
Yeah. So, and as it turns out, the bone healed successfully. But when the patient came into the clinic, their walking was very slow and guarded. Balance was poor. They had a definite fear of falling movement pattern. Pain had spread into the back, into their low back and into their knee, down their leg, and their activity levels had dropped dramatically. Now, the bone had healed, right? But the body still moved like it was injured. And that's just it, is that sometimes in our medical care, the doctors fix the immediate problem, but then all the problems around that is not something they necessarily address.
So on paper, the patient looked fine, right?
Yeah, exactly.
X-rays looked great.
There was no reason.
Yeah,
there was no reason for them not to have full mobility and full ability to walk and return to all their activities. In fact, the doctor was stumped as to why the patient wasn't doing better than they saw before then. So what we want to know is, well, what was actually wrong? Strength wasn't the main problem. And so often people go to the physical therapist and they get all these, exercises like, oh, if we just strengthen it up. And, what I want to point out is that the real issue is the loss of joint signal, right? So,
could you say that one more time?
Okay, so strength wasn't their main problem. The real issue was a loss of joint signal. The joint wasn't telling the rest of the body or within itself, it wasn't communicating as to what should happen or what could happen. Right? And so to understand this, we need to understand where movement sense actually comes from. So where joint awareness comes from. Your brain knows where your leg is, not just from the muscles, but primarily from the joint itself. So joint position sense, what we call proprioception, comes from the joint capsule, the ligaments, which are thickenings in that capsule, right? And the capsule is like for example, the rotator cuff. There's a capsule, and the rotator cuff's not a capsule per se, but it's a structure that surrounds and keeps fluid inside the joint so the joint can function and ride on fluid instead of riding bone on bone. That's why bone on bone is bad and a normal joint rides on fluid. And it's the joint capsule that keeps that synovial fluid contained in the joint and under pressure so that it lifts the two pieces of bone apart from one another, right? So that's where proprioception comes from. It comes from that joint capsule. It comes from the ligaments that are thickenings on the joint capsule, right? It also comes from the cartilaginous surfaces of the bone. So that the menisci in a knee, or you do have somewhat of a meniscus in a hip. and then the pressure and load within the joint. Like, so where pressure rides in the joint stimulates the joint and tells it where you're at in space. Okay, now these tissues are constantly telling the brain where the joint is, how fast it's moving, how much load it's carrying, and whether the movement is safe. Like, are we about to hurt ourselves so that we should stop all motion? Or are we in an area where we're moving from point A to point B and it's a very safe and expected and something we can control? And anybody that has gotten too close to the edge of the range of motion, and you'll notice, like, for example, your muscles might spasm or the muscle might shake because you don't have control of that area, and your nervous system's going, ooh, we don't know, not safe. So that's an early indication that, oh, that's an area or a range of motion of my joint that I don't have good proprioceptive sense in. Okay. So important things to have. So if this signaling becomes distorted, the movement becomes uncertain and protective, right? So for example, muscle spasm. And that's exactly what we had here. We had someone who's from the scans and from the x-rays, hey, the hip was perfect. They really couldn't see why there would be a problem. What they can't see is the signals within the joint itself. Now, there's
Can I just add something to what you were saying there?
Sure.
Is when my patients come in this way too, it's something they can't just stretch away, right? Like the muscles are tight, the soft tissue's tight, and they stretch it and nothing happens. And so it's not just this voluntary, like I'm just guarding myself. It's automatic. It's not
Right.
beyond will to overpower.
Right, exactly.
Yeah. Yeah.
You have no control over it. And stretching muscles, and notice that in there, I didn't say that any of that proprioception came from muscles, right? So you can't strengthen proprioceptive sense. And since proprioceptive sense controls the motion, you can't stretch a muscle to get to the place that you need to be. You have to stretch something else. And those stretches don't look like muscle stretches. Like people say, oh, I'll stretch my hamstrings. I'll stretch my glutes. I'll do this stretch. I'll do that stretch. That's not what these stretches, or that's not what treatment of the joint capsule looks like, right? So to understand some of this, we need a little background information. And so there's a law in medicine called Hilton's Law, and it's why joints and muscles share signals, right? This relationship was described in 1863 by John Hilton, Dr. John Hilton. And his law states that the nerve supplying a joint also supplies the muscles moving the joint and the skin covering those muscles. So joint capsule irritation or motion restriction affects muscle activation, movement coordination, perception of pain, and protective muscle guarding. Just like we said, you can't stretch out of this. It's out of your control. Joint dysfunction becomes muscle dysfunction, and muscle dysfunction feeds back into your joint pain. Okay, so then you get this pain, what we call a loop, a pain loop, right? And it just goes on and on and on and on. You can't move, and so then that causes more inflammation, more irritation, and because of the inflammation and irritation, you can't move the muscles guard even more. Okay, so the hip is neurologically complex, and here's where it gets fascinating. The hip joint isn't formed from a single bone. The acetabulum, or the socket, and the femoral head, right? So the ball and the socket, it's a ball and socket joint. So the acetabulum and femoral head develop from 3 separate embryological bones that fuse during early puberty. Yeah, early puberty, folks, not at birth, not until your kid's 16, 17, 18, which might be an argument for not playing tackle football or tackle soccer or having some of these sports where there's too much contact before the age of 18, because the bones themselves have not fused. And we're talking the hip, kind of an important one in most sports. So that means that there are multiple neurological territories contributing to hip joint sensation and control. Proprioception is dependent upon where in the joint the 2 bones are and how they interact. Is it over here? Is it up there? Is it down here? Is it in the front? Is it rotating? Is it sliding? What's going on in that joint? And then that tells your nervous system what to expect and how it should control the rest of the system to have balance, to integrate motion into complex systems, like dribbling a soccer ball all the way down the field to score it. You won't be able to do that if you're not getting the right information in your hip. Okay,
That's
So that
fascinating.
means-
And I just wanted to point out that that's one of the things that fascinates me about osteopathy. This model of wellness is that you study embryology to figure out how those structures develop in embryo and utero, I should say, and how they, how those structures form and how it contributes to the function of those structures later in life. I think that's so cool that I'm not aware of any other medical discipline that looks at that foundation, that embryological foundation, to figure out how people move and how those structures in the body function. I think that's so cool.
In fact,
Yeah, it
like
is very
even
cool.
when we're in classes, when we're in college and going to classes and stuff, embryology is just kind of presented almost like as a tribute to where we came from. It is not focused on as like a big deal. And I think we kind of glaze over it in a couple weeks and they're like, "Okay, glad that's over. Now let's start some histology or something like that." But it's not even presented as something that's important, and it's absolutely essential. So
Well, and it's also one of those things like for technically embryology is genetics. And we've started teaching genetics, but we're not really teaching the embryology. And in some ways, embryology is the story that's told when you have the genetic information. So genetics are
Mhm.
almost like the mathematical equations of how of what happened. You know, this gene did this and split into that, and the Hox gene did this and was then stimulated, and then it did this on top and that on the bottom. But that's more of a mathematical relationship sort of thing, and it doesn't really inform our brains about the relationships of actually your diaphragm split off a piece that became your side back muscle that then split off a piece and became a ligament in your pelvis that became your hamstring that became your fibula that became an ankle ligament that became a muscle that attaches to your big toe. There's a story and it's almost like the oral tradition of history here, and so that's really the difference there is you don't have that oral tradition of history. And so we have these mathematical equations that you don't really see those relationships. So it really helps to understand them in that oral tradition of history. So yeah, no, it's fascinating, but it also gives us it gives us humans, mere mortals, a better insight into how things arise and then understand the relationships of how they might interact to allow function. And that's
Yeah, I
exactly,
think that might be a good topic for a future episode.
yeah.
A little
Okay.
bit more about embryology. But anyway, I just wanted to digress just for a second to, highlight that uniqueness about osteopathic manual therapy, taking into account embryology. But just to kind of summarize what you were saying, those those structures as they kind of fuse together, they start kind of communicating together, kind of coordinating together, to tell the brain, this is what how the joint's feeling. And so the brain has to kind of adjust and tell the muscles to do, to adapt their gait pattern, or, when they're running, you have to run a certain way so that the joint moves as optimally as possible. Am I getting that right?
But yeah, yeah, definitely.
Yeah.
Well, and
So I
you
just
think
wanted to
about,
summarize.
yeah.
Go ahead.
Well, you think about how you'll fire one muscle group, and then the timing has to be right so that muscle group performs something for you, and the next muscle group kicks in, and the next muscle group, and the next, and so you are moving between like A, B, C, A, B, C, and then if you can do that in a controlled and faster way, then you can run versus just walk, or you can walk quickly,
Mhm.
or you can actually walk instead of stand. Right. So again, it builds in complexity, but from very kind of sedate beginnings, you get higher and higher function depending on your timing and your integration. But if you lock that timing and integration out, you drop right back down to not being able to function.
Yeah. So sometimes, like, so when you have surgery or some other kind of trauma, those signals get disrupted, right, in the
Exactly.
healing process or just in the surgery process. And so I think you're going to talk about a little bit, some of the effects of that going forward, right?
Exactly.
Yeah.
Yeah. This
And
is the
Yeah.
story.
maybe it would be, sorry. Maybe it would be good to point out too, like, I guess, like for a layperson, like what's, I mean, maybe we aren't super clear about what the embryology is. Embryology, if you understand that as a practitioner, it helps you understand, okay, well, these other tissues in different parts of the body are also that same type. And so if we're having a hard time stretching or something isn't just a simple fix, then we need to check that other related tissue because they communicate in a way that, that either ramp up or shut down, or they kind of coordinate their things together. And so there's this tissue to tissue communication, right, Neil? I mean, when that how you explain it,
Yeah,
like
exactly.
that
Exactly.
that something isn't simple, then you need to check that same embryologic tissue to be able to provide treatment there, and then be able to allow that the target tissue, what you're trying to fix, to be able to resolve.
Exactly. And this is really the crossroads of biomechanical information, biochemical information, and bioelectrical information. And that's how they move back and forth between those three things. By stimulating the joint sensors, what is mechanical information gets transmitted into electrical information. If that happens properly, we move fluid in and out appropriately. And the biochemical is saying, hey, we're healthy, we're moving, we're grooving, this is going to be great. If we don't do that properly and there's excessive inflammation, then the biochemical message goes one direction. Meanwhile, the person's like, yeah, but I can run, but I keep getting swelling on my knee. Yeah,
Right.
that's a problem.
Yeah.
That one of your three signals is incoherent. And that means there's a problem that we need to fix now before all three go bad. Because then, for example, this patient here, once all three have gone bad, like lots of trauma and a pretty bad situation, now it's very difficult to get all three to become coherent again. And
Yes.
then that really locks them out of function, right? So there's really the beauty of it. If it's complex on the one hand, and understanding, well, these cells that were set down as an embryo, and then these cells divided and made those cells, and then so there's all these relationships, and you understand why. Like if this cell is related to that cell, is related to this cell, is related to that cell, that when they communicate, they're going to communicate because they're family, right? There's better
Yes.
communication in the family than there is to strangers, and that's exactly it. In fact, we want that to happen. We want three parts to the hip because there are times where we need a completely different motion, and we don't want this line of cells to be worried about abduction. We don't want this line of cells to be worried about flexion, like lifting your knee. And we want this line of cells to be only concerned with pushing your leg back. But we want those other cells to keep you upright, because if we told one of them to turn off and two of them turned off, you'd fall down.
Mhm.
Gotcha. So can you talk about a little bit what happens to people after they, like, with a hip fracture? What happens to them after, while they're recovering from surgery or injury?
Yeah. So what happens is you've disrupted this whole process with trauma. You've torn structures, so now they have to be reworked and healed. And healing's never as good as it was before, but it's a pretty good situation. But unfortunately, there's been a lot of biochemical signaling in the area. So there's a ton of inflammation. There may be blood involved, especially after the surgery. There's blood involved, it really blows the biochemical signaling out of the water. It's an acid. So it causes all sorts of problems. And we have all this inflammation because your body's like, hey, who put this medullary nail here? I don't know where this came from, but we need to get this out
What
of
am
here.
I supposed to do with? Yeah, what am I supposed to
Yeah.
do with
And with the
this?
nail.
Yeah,
Yeah.
exactly. And what eventually happens is your body actually puts a coating over it, and then it can't recognize. Then immunologically, you don't recognize it anymore. So that's another thing that causes the inflammation to go down. But you also have to have the appropriate healing response so that area gets the bone heals in, and then that helps cover the nail screw, and that then even that screw gets covered over with a covering that then your body can no longer recognize, and it goes, well, we have it contained, so it's not a problem. So it's things like that, and then just the inflammation in the tissue. Uh, Now you have disrupted tissues, like so different layers of tissue are supposed to slide on one another. Well, if you've disrupted those and they've kind of scarred up, they may have stuck to one another. So you need to get them moving again so that you can get smooth motion in there. Otherwise, when one part of the joint is stimulated, it's also stimulating another part. So you're getting an improper biomechanical signaling. And so normal walking or running or squatting or any of those activities, you're pulling on the wrong set of muscles and giving the wrong information. So you can't get muscles to relax when they're supposed to relax to allow the motion, or the tissues to stretch, because the muscles are constantly going, no, that tissue says it's under tension and my job is to hold. Okay. So that's really kind of the underlying aspect of some of this, and why embryology is so important. It really shows you that there are and in a hip, there are multiple neurological territories contributing to hip joint sensation and control. And different regions of the joint stimulate different muscular responses when loaded. In healthy motion, load shifts smoothly across the joint surface, right? That joint is going to move up and down as you change the angles of your hips. Say you're skiing or say you're walking, you're bending down to the side or doing something. Different receptors activate, they're stimulated differently. And so then stimulate, they'll stimulate different muscles, and then also muscles further up in the body for balance. Like if your hip is moving, then your upper neck had better change position. Otherwise, you'll fall over. And that's one of the things we see with this poor balance, is that before, this person had so much hip motion, or they had enough hip motion, that any iniquity, like stiff neck, especially as people get older, they get a stiffer neck. Any problem there isn't as big of a deal. But now all of a sudden they've had this hip injury. Now they don't have the motion or the sensation in their hip. And now that lack of sensation and motion in the neck becomes much more important. And again, back to how it is that we look at bodies. If the neck and the hip and the low back can't move the same and the mid back move opposite, this person's going to have balance issues. And that's also part of not uh, overemphasizing motion in a hip that hasn't had a history of that kind of motion. This gentleman was in his later 60s, and so how much hip motion does he have? Not a ton. He had plenty before he hurt himself, but now that he's hurt himself and diminished that, and now we're trying to improve it and take it back past where it was before. Now his neck is an issue. Now his mid back is an issue. Now his lower leg is an issue. So you can see how different receptors activate and can respond in different ways or not. Also, of course, because the receptors activate, we get different muscle groups to respond. And then the motor patterns will vary naturally. They'll be more appropriate to the demands of what the person's doing. They'll move the right way. And this is what we call creating adaptability, efficient walking. Adaptability is the ability to adapt to the needs of the moment to maintain balance and to maintain gait or walking in this case. Okay. So after the fracture and after the surgery, through that whole process, the capsule has become stiff. The ligaments have tightened. They may have been injured directly, or they're just tight because of, like I said, the blood or the inflammation, pre or post surgery. And then the cartilage loading pattern changes. In fact, what it does is it's not that it changes; it just doesn't change. One part of the cartilaginous surface has contact with the bone, and the bone, the ball in the socket is no longer moving around freely. And so you're always stimulating the same area. Well, guess what? Now we start wearing away the cartilage because that cartilage is always under duress, right? So we actually set ourselves up for the future need of a total hip replacement. Okay, so you can see how that's not useful. Minor motion in the joint disappears, right? So that ability to shift, and what minor motion is it's not the major motion of flexion or extension or abduction. It's a flexion, extension, adduction, abduction. It's that ability to slide around and to optimize by just a quarter of an inch or an eighth of an inch, optimize the angles and the force vectors of the muscles and the ligaments so that everybody works together to accomplish a goal. And in that way, our joints can be quite small. If our joints only rolled, for example, and didn't have that minor motion, we would have huge joints. Right? We'd be elephants. Yes. So that would be a problem. Yeah. So in order to maintain a small joint, you have to maintain that small joint to allow all the motion and the function that we have. Okay. So now, instead of varied stimulation across the joint, the brain receives repetitive, incomplete signals, and it keeps coming out with the same answer going, well, fire these muscles. Well, fire those muscles. And the person's going, well, I feel muscle cramps. I can't move. And the nervous system responds with guarded walking, muscle overuse, reduced stride length, poor balance, and increased fall risk. And the motor programming is just stuck in a short loop. And this is where, okay, let's go and strengthen that person. Well, they're stuck in a short loop. And the strengthening, the muscular strengthening is not going to address that loss of minor motion and the biochemical, biomechanical, bioelectrical signaling. It's just going to say, hey, we're going to take what you have and do it 10,000 times. Well, that's a recipe for destruction because it's going to just really irritate the system. And so the system's really going to get locked in and guarding. It makes it very difficult to fix and make headway in that because now, of course, you're doing damage day by day to that joint. Okay. So
and years later, we talk about this in class when you teach us all the time. The capsules are also part of our immune system, right?
Right.
The hip is a hematopoietic center, so you're starting to have like real health problems that are coming from that stuck capsule.
So yeah, so we produce red and white blood cells in our bone marrow, right? And so if you don't have hematopoiesis, means making hemoglobin, making red blood cells. So we make our red blood cells in our joints and in our bones, especially our long bones. Now the thigh has for quite a while into life, our femur does produce red blood cells. Well, if you stop that signaling in there, it just all that space gets replaced with fat inside your bone, which actually degrades the health of the bone. Right? You're not supposed to have fat in there. Fat has doesn't have the same signaling as a fluid, and the production of red blood cells and the other factors that are in there. So you have a constant turnover of growth factors, of nutrition on the inside of the bone. Well, all of a sudden you just pack it with fat, and now the inside of that bone is not really getting the health that it used to get. So, right, it really breaks that down. So your whole immune system is breaking down because now your leg bone, it stops being a part of your immune system. You don't have white blood cells in there. You don't have red blood cells in there. It just sits there and doesn't get a lot of oxygen, doesn't do a lot. It's not very active. So yeah, it's a very bad situation. So now instead of only strengthening muscles, we focus on restoring joint motion, specifically minor motion, not the major motions. We don't go and stretch you out manually. That's not what we're talking about. So gentle capsular mobilization. We have to make that capsule work. Fascial and ligamentous tension release, because we have to get nitric oxide in there. There's more and more information about nitric oxide. Nitric oxide opens up the capillary so that a red blood cell can move through, so more blood can flow into an area. It actually makes tissue more distensible. We have to restore pelvic and spinal motion, right? And you see this on the internet all the time. There's the fun little guy that's like, oh, don't put your arm here and crack, oh no, do it this other cool way. I have a different way to crack your back. Just cracking a joint does not restore the motion. It does for a moment, but then that motion freezes right back up. Now, if you have just a stuck facet or just a stuck joint and that's all it needed, yeah, it would be a wonderful fix. But problems never come all by themselves. They're always multifactorial, and they involve all those tissues. They involve the connective tissue. They involve the nervous system tissue. They involve the joint itself, the joint surfaces. So you can't just crack it and go, yep, oof, fixed it. That's great. That's just one of the signals that's going on, and it's only a temporary change in the signal, and the other signals overwhelm it, and it goes right back to its dysfunction. So pelvic and spinal motion, foot and ankle adaptability. Can the foot and ankle take the pressure off the hip? So any past problems that this person has had, or did they injure it in the fall? Diaphragm and rib mobility. Again, back to that. Can the person, can they keep their eyes level with the horizon? Can they get their feet flat on the ground? And can they breathe in between while they're doing activities? Can they twist and then still breathe? Or, you'll hear these people, they go to do something like put their shoe on, then they go, oh, I can't breathe. Okay. So that tells you that their diaphragm cannot function in various positions. And we have to restore that. And then gradual load tolerance. Can they tolerate the load into their hip? Can their hip absorb that biomechanical information, distribute it appropriately, get the right biochemical signaling, get the right bioelectrical or neurological signaling? Can it get all those things? So that's what we mean by gradual load tolerance. It's not just, can they put up with the pain of putting their weight on their leg? It's, far more in depth than that. And so, there are people that they go, okay, let's just put on the gate belt, walk you down the hall. And I have a PhD for this, or, I have a graduate degree in walking people down a hall, but they're not looking at the gradual load tolerance and understanding all these other factors. So it doesn't matter what level of education you have if you don't understand this information. So there are plenty of people out there walking around with, that they're a doctor of some sort in whatever discipline, and yet they don't understand this very basic information of how a joint should function. And so they just, let's just grab the gate belt and walk you down the hall. And we do that 5 times and magically you're better. And then the person goes home and then they come to me and they still can't walk and they're having all sorts of problems. So as we,
I was just going to ask, Neal, could you maybe just elaborate on the difference between minor motion and major motion?
Sure. So major motion is like flexion, extension, rotate, like full rotation, abduction, adduction, right? Like if you take your shoulder across, that's adduction, and take your shoulder out this way, that's abduction. So those are major motions, right? Those are big, broad stroke motions. And that's, of course, how we measure motion. Say, can this person function? Can their shoulder function? Can their hip function? Now, minor motion.
So is that what, people who aren't focused on the osteopathic model, is that what they look at generally?
Right.
Are the major motions. Okay.
Exactly.
Sorry.
So physical therapists use a goniometer, right? An angle measurer. And they'll say, let's look at your shoulder. You're 123. And you see that a lot of times.
Yeah.
Yeah. You full your gross range of motion. And it's like, yeah, gross range of motion is great, but you can't have gross range of motion if you don't have the minor motion. If the joint doesn't have a little play in it, a little slop in it, it can't move to the most advantageous position. Because again, back to we have these very small joints. And the reason we're able to have these very small joints is because we can change what we call the moment of rotation, the point about which a joint functions. And sometimes it's optimal for that rotation to occur here to maximize the strength of the muscles that cause that motion. But if we move that range of motion or that center of rotation back here, that moment of rotation, just a few centimeters off, now it makes it much more advantageous for a whole different set of muscles to do their job. So we don't get overuse
Yes.
syndromes. We don't have to have muscles the size of elephant legs. And that's what allows us to keep everything really small, but also have these very quick, small movements and maintain easy balance. So that's really the
Yeah. So
difference.
our minor movements are more for like posture, like balance, like making sure you don't fall over, or that you don't have to like keep stepping around, to stay upright.
Actually, they are for every motion you do. So
Okay.
if you want to have a flexion of your shoulder, if you don't have all the minor motion that requires, then you're going to have limited flexion of your shoulder. People come in and go,
Mhm.
oh, I can't move my shoulder up. And then, as we were taught in school, oh, just shove it. You can't shove it because you're lacking this. It's kind of like, it's like paying the taxes on, hey, I bought a car, but I didn't pay the taxes. You're not going to have the car very long. And that's exactly it with shoulder motions. Like, you have to pay the tax. The tax is having this little slop in the system where, if you notice, as people, they'll kind of jimmy and jockey. Oh yeah, look at that! I can get my arm way up there. But if they had to go straight up, they're like, I can't. Okay, yeah. So it's that utilizing minor motion that allows the major motion. So major motion is not possible without minor motion.
All right. Yeah. Thank you for elaborating on that.
Yeah.
That's awesome.
So as you restore the minor motion, the joint receptors begin signaling again, because all of a sudden, the ball is moving around in the socket, stimulating different receptors. Well, that means that the motor programs start being appropriate to what the person is doing. And so now they start using their muscles and their tissues in an appropriate way, which decreases the amount of inflammation. It actually helps the muscle be healthy, right? Because the proper use makes the muscle stronger, and the movements become safer and smoother. The person has better balance. And so that's how you strengthen. That's how you strengthen a person. You don't give them the major motions and say, minor motions be darned. Well, we don't need those. Like, no, you have to restore minor motion. And that is the cascade that allows all this other stuff to function properly. So, and this changes everything, because as joint input is normalized, the muscle firing patterns are improved, balance is improved, pain decreases, inflammation decreases, walking efficiency improves. The person doesn't have to breathe as hard or as often. Also, their confidence, their outlook, and there's a lot of practitioners who talk about somato-emotional release. Hey, if all of a sudden you can walk and you couldn't before, funny how your emotions are a whole lot better, right? So that's my version of somato-emotional release. Get the person moving again. They're going to be happy. And now they can go back to their activities. And this is the whole thing that asks me all the time. Like, oh, I need this extensive exercise program from you. No, you don't. You need to be able to do the things you like to do, because then I just need to get out of your way and let you go do them. Whether that's gardening or, working in the yard or, doing whatever activity. Like, oh, some people like to ride bikes or walk their dog. My job is to not give you some extensive program that, you're not going to do in, more than twice. It's to give you the motion to do what it is that you want to do. Okay. And that's when, and as the activity increases, the bone and tissue health improves naturally. And then the system kind of reboots itself. It kind of goes, oh, and then it's able to heal. It's able to thrive again, right? It comes back to health and vitality. So now, I'm not saying that this just happens immediately, but the changes begin to take effect immediately, and people start to see a
Yes.
difference very early on. Autumn, you've had plenty of these patients.
Just this morning. Even this morning. Yep.
Exactly.
Yep.
They're constantly coming in and you're going, well, let's start here. So eventually the patient, this patient of mine, he returned to his part-time work. He was still working he worked for himself. So he got to go back and be there, which he loved, because he loves to talk to people. So that was great. And it's not because we forced strengthening on him, but it's because we restored the signals that needed to be there, right? We understood where the blockage of the signal, whether that was biomechanical, biochemical, bioelectrical, and we went in and we rejiggered the system and allowed that system to bring itself back online. And that got him back to his function. And that's really the part of why I love to do this job. You love to do this job. It's just, yeah, it's really rewarding to see that.
Yeah. Absolutely. Makes you feel like he's all this time to study and practice is worth it for sure.
Exactly. So the bigger lesson here is that after a hip fracture, bone healing is just the beginning. Recovery requires restoring joint motion, neurological input, muscle coordination, mechanical load transfer, right? So you have to have all those. And then that gives you the correct biomechanical, bioelectrical, biochemical signaling. And you undo the bad signaling and bring in new signaling that really brings everybody together. So when the joint signal returns, movement becomes safe again, and the biology takes over. Right? Humans heal. I love to tell my patients, it's like, hey, remember, every night you heal as best you can. If I remove the barriers to you healing, that means tonight you're going to start restoring your own hip. Right? We make it possible for the healing process to take place. We remove barriers to that. And that's exactly what we're talking about here. So your big takeaway here is that joints don't just move, they communicate. The capsules, the ligaments, and cartilage are constantly guiding muscle activity and movement strategy. If motion disappears, signaling disappears. You restore the motion and the body regains its ability to move, adapt, and rebuild. So healing bone repairs structure. Restoring motion restores life. When joint signals return, movement improves, confidence improves, health improves. So restore motion, restore signal, restore confidence, right? And that's really just our motto is like, hey, here's how we do this. We get in there and it seems for us, it's a little bit repetitive, but you always go for the basics.
It's still fun.
It's still fun, especially when people, what the heck did you just do? I don't get it. Like, yep, it's magic.
Can I tell you one that happened this morning?
Yeah, sure.
I have an older gentleman that came in and he's been having some prostate problems and he was going to go get roto-rooted, and all that stuff. And I was like, well, why don't you come in and let's take a look at that first. Well, we just had this class a couple weeks ago about that, with that additional scan exam, wink, wink, that you hadn't showed me for a while in those times. Anyway, his center of mass had been inappropriate. And so he was actually grinding on the pelvis. So we were able to change that signaling through the prostate. And now he barely gets up to go pee at night. And he's like, things are way better. And, prostate has all kinds of implications. Life is way better for him and his wife now that we've got his alignment better, but that signaling has been repaired and it actually is healing that organ. And then it's having this huge spillover effect and all these other things. So it's fun. It's fun to learn new things and to see how it affects each person and then be able to have the skills like how you're teaching us to be able to think through those problems and go, maybe I just don't just try and drain that thing directly. I wonder what the feet are doing. I wonder what the other postural problems are doing and where that center of mass is. And why is he having, everybody has a growing prostate, right? Why is this guy having such a hard time right now? And so far he's like, I'm not doing that surgery. I canceled it. So I'm like, well, keep going. You're still getting better. So let's keep going at it. So anyway, that was fun today.
Yeah, that's incredible. And it wasn't like, oh, I did this fantastically huge thing. You're like, I went back to the basics and I restored the signal and his functioning came back and his body took over. Nobody had to do some fantastic intervention.
Yeah.
Your intervention.
No additional exercises, no nothing. What, sweetie?
I just wanted to ask, what did you do to help change that center of mass so that it wasn't, so heavy or focused on the pelvis?
Yeah, so his posture pattern, when he came in, Neal just explained to us how to do this. Is it posture pattern A or posture pattern B is what we talked about in this last class. And a new assessment that we're able to do to help us really nail, like right away, within a couple of minutes, like exactly where we're going to have to go for treatment. And so I just worked through those spots with his posture pattern. He was putting too much strain on the abdominal wall and using those pelvic organs as like a support structure instead of just, having them just sit there and, kind of do what they're supposed to do. They were too much weight bearing. I also had actually 2 pregnant moms that were having early Braxton Hicks and stuff. We did the same thing and it took the pressure because the baby was supporting too much weight because the strain was on the body, the abdominal wall. And so we were able to work through that, with the feet and the hips and the knees, did some work with the ACL, did some stuff with the low back, did some stuff with the upper thoracics and the neck, and then got those movements right. And then they stopped. You could even just see the person just kind of sink back into the table because that center of mass wasn't so far forward and I wasn't having to use those pelvic organs as a shelf. So
cool. So you started at the feet and kind of worked up?
No, on this guy, I started with the upper chest because that's where the scan exams told me to go. And then I made sure I, cleared out those things. There's always another end of the stick somewhere. Like Neal said, there's nothing that's in isolation, but with these different people, you're like, oh, now your prostate problem makes sense. Now your early Braxton Hicks makes sense. Now your, subchorionic hemorrhage makes sense. Now that's healing up in one of these girls. So young ladies. So it's just really incredible to have, in some of those, you're like, that could be serious at a certain point. So, and a lot of people wouldn't be able to find that. And, it was able to find it much quicker now because of this class we just had a couple weeks ago. So anyway, I'm grateful, Neal. Thanks.
That was a good class. That was fun.
It was really fun. It was good.
Also, so Neal, before we wrap up, I was just going to ask what's a takeaway for people listening who, maybe have joint issues. Are there things that they can do themselves to kind of help encourage minor motion in their joints?
Yes.
Maybe before they have to go find, like you or Autumn or other practitioners, are there things that people can do on their own to help them?
There are. That's one of the reasons. Like you see, so many people already have like a 5-inch hard rubber ball, or they'll have, say, a cross ball, and laying on those, whether that's on your side, on your back, right where the femur and the acetabulum come together, which would be right in the middle of the buttock, right? So right in the middle of the glutes, which is where you should have the joint. If you lay on that capsule encompasses that area. And so if you lay on a ball anywhere in there and you find a really tender spot, and that goes for that, whether that's a shoulder or any joint really in your body, if you can find something around that joint that is tender, that's most likely the capsule. And that's where you should put pressure, is to really get that capsule to be able to let go and to function properly again. So for example, in the hip, it really is the use of, whether it's a lacrosse ball. I mean, some people have to start with a tennis ball because it's too painful, but either a lacrosse ball, which is, they're like big, or even a 5-inch ball. The orb is what I tell people to get all the time. Yeah. And then just to lay on those. And we have demonstrations of those. I think, Autumn, you probably have some videos as well on my YouTube channel. I have if you go to my website, pursuitpt.com, and you look for patient resources, there's a link to my YouTube channel. And in the YouTube channel, now you have to click on videos because, YouTube has this weird thing where they only do a little short, like, oh, here's 5 videos. And people go, you only have 5 videos. If you click on videos,
it's got way more than that.
Yeah, it'll show you the 5 pages of videos I have. So I encourage you to go to that and look, and then see, how can you do this for yourself? An ounce of prevention is worth a pound of cure. So the earlier you start doing this, as soon as you're having a problem, if you start doing this stuff, you're more likely to have much better outcomes right away.
For sure. So that pressure kind of just signals to the joint capsule, hey, just relax.
Right. And restores that motion.
Don't be so uptight. Don't be so tense. Yeah.
Exactly. Right. We can all use that advice. But yeah.
Yes.
So there you go. I mean, so.
Fantastic.
Yeah. So thank you for joining me, Autumn and Brent, on the OsteoSignal podcast. And those of you at home, please, if you want to hear more, please check out rumble.com. We have all of our podcasts posted there. And so until next time, move well, adapt well, and keep your signals strong.
Thanks for joining us on another episode of OsteoSignal with Neal D. O'Neill. For more information, please visit pursuitpt.com or pursuitperformancetraining.com. Our music was written and performed by Sky Toes. Copyright 2026 by Neal D. O'Neill.